Good evening. This is Stephen Lloyd. I'll be your instructor in iTech 770 medical databases. We're going to have a wonderful semester. I hope that I can give you a thorough background of medical informatics and also stimulate a little interest in the research I've been doing in trying to create the data necessary to support artificial intelligence. Currently, medical information is very much controlled by the larger hospital-based systems, and they have a construct they call the electronic health record, the EHR, and the electronic health records industry has been consolidating. There used to be 20 or 30 different companies that marketed various systems, from dietary systems to laboratory systems to personnel systems to diagnosis systems, radiology systems. Various different vendors had different components of it, and gradually some of the larger vendors acquired other subsystems and ended up with a all-in-one product that allowed the hospitals to look to one vendor for all of the services. And this consolidation has come with some associated problems and flexibilities, in that the vendors are sort of in control of the market and what the capabilities of their systems are. And the two main vendors that we see is number one is Epic. And I was actually involved in the initial creation of the Epic system. It started using a language called MUMPS, which was Massachusetts General Hospital, which is the hospital associated with Harvard Medical School. They had a very forward-looking, high-technology computer manufacturer in the area called Digital Equipment Corporation, and they came out with some early mainframe computers that were a little less expensive than some of the competitors, and so they were able to work with this Digital Equipment Corporation, which we called DEC back then, but a lot of people call it Digital. But they developed this MUMPS language, and the inventor of Epic used that system to develop the software to help run her hospital in the Midwest. And she was astute enough that when the hospital realized they needed to develop their own software system to answer some of these application quandaries and challenges, that she was able to get permission from them for her to have the control of the intellectual property. So she developed on the hospitals, while she was an employee of the hospital, a system to help that hospital. But then she was able to take all the software that she developed and market it outside the hospital. And now it's a multi-billion-dollar entity, and it's been extremely successful, but it comes with some problems. I'll take a break for a second. So what I would like to do now is to go through a PowerPoint presentation about the research that I've been doing. The project I've been working on is called XHealth, and it's a reimagining of primary health care. I believe that the future of improved quality and lower cost in healthcare is definitely dependent upon our ability to apply the principles of artificial intelligence. As we know, artificial intelligence is going to change so many aspects of our economy, and healthcare is not going to be excluded. And so I want to try to share with you during the semester the opportunities we have to enhance medical informatics by using augmented intelligence or artificial intelligence at the point of care. And we're going to try to restore the primary care physician to their previous role of being your doctor, the doctor that makes the decisions about what what your diagnoses are, who's going to help treat you, and has an involvement in every aspect of your health care. And our overall goal is to try to double the quality of health care at half the cost. What I'd like to share with you first is what's happened to healthcare since I graduated from medical school. I finished my internship in 1975. And back then, 75% of the healthcare dollar went to physicians. Only 5% went to hospitals. Only 5% went to the insurance companies. Laboratory and imaging just took 5%. Fast forward now 50 years, and all of a sudden the hospital is now taking 34% instead of 10%. And the insurance companies are taking 22% instead of 5%. And the doctors are now down to 17% from the previous 75%. So what we've seen is that an erosion of the amount of the capital that's used to pay for healthcare, an erosion in how much is going to providers, to doctors, and how much is going to the insurance companies, the hospitals, and big pharma. Back when President Eisenhower was leaving office, he gave a very cogent lecture, a speech, saying that the America needed to be very careful about the military industrial complex. And this he forewarned was so powerful and had so much influence on the Congress that we were in danger of being thrown into unnecessary wars just so that these companies could make exorbitant profits. And I think the same thing has happened in healthcare, that the insurance companies, the hospitals, and big pharma, the medical industrial complex instead of the military industrial complex, are now in control. And as you can see in advertisements for pharmaceuticals on television, the lobbyists have a great influence, have a great control of Congress. And so what we've seen is the total budget go from 100 billion to 4 trillion. So now we're spending $4 trillion every year, and the proportion that's going to doctors has dropped dramatically. And what our goal is with this XHealth system is to cut the total budget from 4 trillion down to 2 trillion. We're going to increase the proportion that goes to doctors from 17% to 32%, which is really going to end up being a net zero change in how much doctors get. But at least out of the total budget, proportionally more will be going to the doctors. But the 32% of 2 trillion is similar to 17% of 4 trillion. But the big drops are going to be in the hospitals. The hospitals, instead of getting 34% of 4 trillion, they're only going to get 25% of 2 trillion. So they're taking a big cut. And we need to discuss how we can do that without reducing access and quality. And the pharmaceutical industry also is going to take a cut. This $4 trillion is actually 20% of America's gross national product. That's 12,000 per person per year. That's $1,000 per person per month. And if you look at the economy in America over the past 30 years and look at what wages have been, how much employees are compensated, every bit of the increase that they've had over those 30 years have been absorbed by increases in their cost of medical care. So when you look at true increases in income, there's been none. In 30 years, there's been no increase in the wealth in the community because every bit of pay raise has been absorbed by out-of-pocket expenses, insurance costs, and medical expenses. So in America, we have the lowest quality, but at the highest price. When you look at measures of quality healthcare like life expectancy and infant mortality and maternal mortality, control of blood pressure and hypertension, America is always at the bottom. And one factor that we must keep in the back of our minds is that employers cover 85% of private insurance costs. So that employers are paying $1,000 per employee per month. And I think they have very little allegiance to the various insurance companies. And I think we have a fertile opportunity to enter that market if we have a better product. Now, this information I just found astounding. It just about blows your mind. If you look at the trillions of dollars that we're spending and look at who's who's responsible for it. On the up part of that curve where you see that 79.3, that's that's 3%, from 97% to 100% of the population. So the top 3% are taking 20% of healthcare costs. So that's 3% taking 20%. And if you take it down to 95 curve where it says 51.2, the top 5% of utilizers, of healthcare utilizers, are using half of healthcare costs. Think about that. Half of healthcare costs are are expended by only 50% of the population. The other side of that coin is we have underutilizers. When you get up to 50% of the healthcare expenses, we're only up to 3% of the population. So the bottom 3% of the population, the bottom 50%, are expending only 3% of the healthcare dollars. So the top 3% are expending 20%, and the bottom 50% are only spending 3%. That's just crazy. It's just, we have to find some way, and no other country in the world has that. Another a factoid that I find interesting is that 25% of your lifetime medical expenses are spent in your last 2 years of life. So the other thing that we need to think about is, what does it take? Who are the underutilizers and who are the overutilizers? There's so many people in their 30s, 40s, 50s that get no health care at all. They just, they don't routinely get screened. And so sometimes that means a woman misses her mammogram and ends up with stage 4 breast cancer, or a colonoscopy doesn't get performed and somebody ends up with stage 4 colon cancer. So it doesn't take much. And once they have that diagnosis, all of a sudden they're in that overutilization category. And so what we need to do is figure out how to keep people from getting cancer or heart attacks, and keep people out of the hospital so that we can do a better job of managing the opportunity we have with the $4 trillion we're spending. We want to equalize utilization, and we want to reduce the rate of conversion from the underutilizer to an overutilizer. Information technology in healthcare, and that's what this whole semester is going to be about, is antiquated. When we look at the electronic health records, especially the Epic and Cerner and the various vendors, we find that the electronic health record is not very friendly. It's not very user friendly, and it's also not very well adapted to using artificial intelligence. And so one of our precepts is that we must make a wholesale change of how we acquire medical information, how we store it, and how we are able to use it for artificial intelligence. And I'll take a moment to explain to you about my hero, which is Elon Musk. I'll go over this over and over again until you're sick and tired of hearing about Elon Musk. But Elon Musk has gone through 3 generations of his autonomous self-driving program, which I hope that during the course of this this semester, we will actually see the employment, the introduction of autonomous self-driving. I believe it's being rolled out in China in the next several weeks. So you will be witness to a huge shift in the economy in terms of transportation. We go from ICE vehicles, internal combustion cars, and drivers, and accidents, and expensive repairs, and oil and pollution, to going to robo-taxis, where you have a vehicle that when you want to go to work, it picks you up with very little waiting time, takes you to the office and drops you off. And then if you own the vehicle, you send it back home again to go to the garage. And when you need to be picked up at the end of the day, you just get on your iPhone and it's right there ready for you. So this is what's happening. Elon Musk, but in order to come up with autonomous self-driving, there's a lot of implied economic value in autonomous self-driving, and you have a lot of other competitors like BYD in China, that's supported by Warren Buffett, that they think that they can copy what Elon's done and be able to create a similar software product that if it's just a matter of programming, that they can copy it and catch up very soon. And Ford tried to do it, and General Motors tried to do it. Um, uh, Almost all the major manufacturers realize that autopilot or autonomous self-driving are going to be important capabilities to have, but they are um, not considering that they don't appreciate how far ahead Elon Musk is um, with his artificial intelligence. And one of the things that I want to go over repeatedly in this course is what different types of artificial intelligence are there, and what are the prerequisites to use that power. Another thing that Elon has that's getting ready to be released is the Optimus humanoid robot, and that's going to be a multi-trillion-dollar product also. And it uses a lot of the same software for artificial intelligence as the autonomous self-driving. But a couple of years ago, after Elon had invested hundreds of millions of dollars in the actual programming of his autopilot, his autonomous self-driving, he recognized that they kept having wrecks, that they'd run into the back of a parked ambulance, or they'd run over somebody going across the street on a bicycle. That no matter how much he put added context to programming, there would still be errors that involved injuries. And what Elon recognized is, even though he had very fancy computers and a lot of hardware and software, that his goal, his philosophy, the algorithm, was to recognize everything in the environment of that car and what it is, and then you can determine what to do based on what is in your environment. Well, he recognized that that wasn't enough. You couldn't just say that something was a bicycle. You needed to know that it was a bicycle with a child on it that was going 6 miles an hour to the northeast. And so he recognized that he had to go, and the terminology he used was to go from scalars to vectors, that instead of everything being just identified as an object in the environment, that it had to be a moving object if it's moving, and then that context would help determine how to respond and how to operate his Tesla vehicle. And so we went from scalars to vectors, which was a huge change. And all of a sudden, he was really getting very close to where he was willing to trust the autonomous self-driving in the real world. But again, he continued to have occasional problems with, like, the vehicle would see a tractor trailer across the road, but it didn't measure exactly right and thought it was something like a bridge above the road and that they could get underneath it. And then we have a accident with serious injuries where the vehicle tries to go under it. So he realized that there needed to be a little bit more intelligence in the operation, and he took it to a whole nother level. And this is very difficult for people to understand that are not in the artificial intelligence um, sophisticated environment. But what he did was called end to end. And what he did, his artificial intelligence software is so powerful that the only input to his program is video files. He can actually take just video data from Tesla cars and have a car operate perfectly just with that data. And they've been gradually rolling it out over the last 18 months, and each iteration where he beta tests it gets better and better. Currently, drivers that are using the beta versions are still responsible for having their hand on the wheel and being able to intervene if something happens that it looks like the program is going to make a mistake. And now with the current version 13, the interventions have gotten very, very infrequent, and most of them would not cause serious injuries. So Elon is now to the point, and I think they're going to release it in China in the next several weeks, where his end-to-end software is able to operate the vehicle more safely than a human driver. And that's what we would like to see happen with autonomous healthcare, is to have enough data in our system that allows us to decide how to treat patients without the intervention uh, of providers that do not have access to the intelligence that's necessary to to make clinical decisions. So we want to take clinical decision making into a new level by by capturing the data in a format that allows us to capture the data in an actionable format and use it for clinical decision making. And we'll talk about that in a minute. I'm going to take a little break. All right, we're back. We're going back to our PowerPoint. Presentation. There we are. So we were talking about how antiquated our information gathering is in healthcare and how that is an impediment to ever using artificial intelligence, because artificial intelligence, by definition, requires machine learning, which means you must feed the system mountains of correctly labeled data, like in the games like chess and Go that artificial intelligence has conquered. They just gave it millions and millions of games, and based on whether they won or lost, the artificial intelligence machine learning algorithms were able to incorporate through multi through convoluted neural networks to be able to gradually increase more and more of the learning. Although it's the magic of artificial intelligence is that these systems cannot tell you why they make the decisions they make. It just knows that they are the best decisions based on the data that they've been fed. So outside of healthcare, Alexa and Siri are routinely used for gathering verbal dialogue with patients. And the nice thing about Siri and Alexa are that you don't have to dictate. The transcription comes automatically with natural language processing, with NLP. But one of the challenges that we found in healthcare is when the patient goes from the doctor and then ends up in the emergency room and ends up sick enough to end up being admitted, and then they spend several days in the hospital, may have a surgical procedure, and then they get discharged home. The various different information systems in the doctor's office, the emergency room, the hospital, the surgeon, the post-op care, back to the community, many times there are serious obstacles to the interoperability of the information between the different systems. And this has caused many, many catastrophic consequences. A good example is the number one cause of death in America is heart disease, heart attacks and strokes and peripheral vascular disease. The number two cause of death is cancer. The vascular diseases cause nearly 800,000 deaths. Cancer causes over 600,000. But the number three cause of death, responsible for 400,000 deaths, is medical errors in hospitals. And so this lack of interoperability of data and being able to communicate the changes in environment from outpatient, from home to outpatient to emergency room to hospital back to home, those each time that there's a change, there's an opportunity for errors and lack of communication. So we need to figure out how to use state-of-the-art technology for both acquiring data like Siri and Alexa, and also in displaying data that should be graphic. It shouldn't just be verbal output saying the patient had a cough and brought up some sputum and had head congestion. It should be something visual. It should be graphic, and it should be interactive, and it should reflect the value of the data. If something's very important, it should be highlighted. It should be very obvious to the providers who are using the system. And so the prerequisites to being able to harness artificial intelligence at the point of care are the ability to acquire the data with natural language processing and the ability to display the data in very creative forms that don't require a lot of physician time to be able to get what's important out of the data. So artificial intelligence, I predict, will solve so many crises, so many challenges in the American economy, including healthcare. But we have to be able to support deep learning for artificial intelligence to make a difference in day-to-day healthcare. We have to capture enough data that shows what happened. Patient presents with a certain constellation of symptoms. These were the interventions that we introduced, and this is the outcome. And so we need to go from algorithmic learning, where we used to try to say, if this, then do this. It now needs to be machine learning, automatic. It needs to be just like Elon Musk has learned. It needs to be end-to-end learning. It needs to be automatic. It needs to be totally autonomous. The computer should be able to help know what the next question is, what the next test should be done, what the next medication should be, and when the patient should come back again. All of that needs to be from deep learning, from machine learning, from artificial intelligence. Once we get there, the cost of healthcare will drop in half and the quality will double. And furthermore, when we talk about health inequities, where we see that there's a big disparity in certain populations, we can eliminate that. Artificial intelligence does not discriminate. And one of the sad things to me as a physician computer science professional is the fact that most people don't recognize. They think that all of that data that we've been putting into Epic and Cerner is going to be of value, that it's gradually increasing the knowledge that's embedded in the system. And that's just not true. It's just a bunch of garbage. It's a bunch of text. It's not going to ever become learning data. And it just frustrates me to no end to try to talk to people who think that, oh, well, Epic has, got so much data, it's eventually going to be enough to support artificial intelligence. It's not. It's not in an actionable format. It's not, doesn't, we don't, and we'll get into the specifics of why and how we fix it in a few slides. I mean, all that text is just of no value. We need to reimagine what a patient is. A patient is no longer a text document. The patient is a vector in disease space. But here are the things that are missing. We do not have criteria for accurate diagnoses. Until we can come up with standards and say, this is how you diagnose pharyngitis. This is how you diagnose bronchitis. This is how you diagnose asthma. And then more than just a diagnosis, yes, no, it's not a Boolean. It should be a severity. We should know how serious the hypertension or diabetes or vascular disease is. If we have disease severity, then as we intervene, as we try to control the blood pressure or improve the diabetes, we should see those disease severity scores drop. And as we see them drop and store that, we know that our therapies are working. So right now we're stuck with these dummy MRs that intrude on the physician-patient relationship, but don't really provide any value in terms of managing patients. We need to be able to manage quality. I cannot tell you how many patients are hurt by incompetent doctors. Doctors do a horrible job of policing themselves. And that's the beauty of artificial intelligence. It doesn't care who it is. It doesn't care politically how powerful somebody is. It's going to look at the outcomes. It's going to say how many of this surgeon's patients ended up with postoperative infections, how many of these patients that had heart surgery ended up dying of complications of heart failure and infection. We need to have a way to equalize our quality parameters and just measure them and send patients to the providers that provide the highest quality, not just because they're board certified in something. And so we need to redefine how we acquire history, how we store the history, how we display it to the doctor who's making the decisions on the diagnoses, and figure out how to do our interventions. And then I can't tell you how many hundreds of billions of dollars we will save by not waiting until somebody has stage 4 cancer, but finding it before it's even stage 1. We can cut hundreds of billions of dollars in healthcare costs. And the same thing with coronary artery disease or strokes. You know, the blockage of that artery did not happen overnight. It's been accumulating over dozens of years, and we should have been monitoring that and finding out when it's time to do something, an intervention that will prevent the stroke, not figure out what we're going to do after we've already had it. One of the things that is of serious concern to me as a former primary care physician is the fact that this system will dramatically increase the volume of data we acquire. And the last thing that the primary care physician wants is to have to read more history and ask more questions. So that's the beauty of artificial intelligence, is that it's going to take all of that data that we're capturing and put it into a vector in disease space and be able to come up with diagnoses that are accurate and justifiable and quantifiable in terms of severity. And then from there, we can do our interventions and be able to assess whether these interventions are reducing the severity of the disease or not making a difference. And if they're not providing benefit, then we should explore other options. So I'm very excited about the fact that we can begin to acquire information from the patient that's actionable, that we're going to ask questions in a form that give us quantifiable information about the diagnosis and its severity. And from there, when we intervene, whether that intervention provided a benefit. We can save $2 trillion. That's a lot of money. That's what Elon Musk is trying to say with the federal government. We can do it all in healthcare. So the clinical workflow, when the patient comes in, if you start at the top, we're going to capture some history, but we're going to use the chatbot to gather much of the history. Then we go to the right around the circle and clockwise. We got to filter out the data, filter out the unimportant, amplify the important on the graphs so that the provider can see what are the important parameters in making an accurate diagnosis. Then we have the clinical decision support that's going to go from, once the doctor is comfortable with the assessment and the diagnosis, that we go into the appropriate interventions, the treatments. And that's as we go around the circle. And finally, we have a dashboard that gives us all of the reports on where this patient stands now in terms of their overall health. So it's a clinical workflow that's supported by artificial intelligence because we're gathering the information and we're offloading so much of the data capture from the primary care physician so that we can virtually eliminate burnout. And here's an example of a patient comes in with an upper respiratory type infection. Here are the various symptoms, the chills, congestion, cough, trouble swallowing, ear pain, fever. And there's every 6 hours over the past 5 days how those symptoms have evolved over time. And the provider can just look at this quickly and say, okay, certain things were minimal, some things were moderate, but it's all consistent with J06.9, which is upper respiratory infection, otherwise not specified, because the patient wasn't bringing up purulent sputum and didn't have fever and chills. We can be comfortable treating the patient symptomatically without doing chest x-ray and blood tests. And that's the kind of information that we need to be able to provide to the patient as we're managing outpatient illnesses. So we've talked about how the database is going to look different, that we're going to have a proactive database that all of the symptoms that we're going to acquire from the patient are based on the chief complaint and the diagnosis the patient already had, and we can ensure that we're going to ask all of the relevant questions. So now we're going to invoke data science instead of just a random collection of questions that seem to be pertinent to the doctor that day. We now have a standardized set of questions that are relevant in every clinical situation to be sure that we don't miss something and that we confirm the appropriate diagnosis. Some of the things that are going to make this project easy to implement are one of the things that the CMS, the Centers for Medicare and Medicaid Services, the federal government, which pays for about 25% of all healthcare in America, they are very passionate about trying to get patients into for-profit insurance company Medicare plans. Initially, when they came out with the Accountable Care Organization, the ACO concept, they wanted it to be nonprofit, small things that were really based on small groups of providers. But when the insurance companies realized how much money was in it, they decided they were going to go in hook, line, and sinker. And now all the Medicare ACOs are large corporations, large for-profit corporations, and they are making a fortune. That's why you see on the television all the time, get your card, that your spending card that you get a $300, $800 a month extra. That's all ACO money. If you qualify for Medicare and Medicaid, the ACO is given enough money that they can give a few $100s to the patient and still make a profit. And it's unholy. It's not what the original intent of the system is. But once the big insurance companies realize that here's a chance to privatize Medicare and make a big profit, if we can figure out how to keep the people out of the hospital, then we can make a ton of money. And it doesn't matter how well the patients do that. What they're doing is they're cherry picking. They're picking the healthier patients, figuring out that, okay, when we looked at that utilization, the healthcare expenditures, they're finding the middle of the road people getting $1,000 a month from Medicare and then being sure that they are only spending $200 or $300 a month. And then they've got money to give the patient a little bit of a flexible spending card, and then still have money left over for profit. Another company that y'all need to become familiar with, I want y'all to look up, is Aledade. This is a company that has formed a bunch of these ACOs and went to the federally qualified health centers. Federally qualified health centers cover about 1 in 12 patients, about 8% of Americans are taken care of by a federally qualified health center. And these are federally supported health facilities, all outpatient, is predominantly primary care, which is family practice, OBGYN, and pediatrics. And they provide a broad menu of primary care services, but they don't provide hospitalization or specialty services. And I think that's a perfect opportunity for XHealth, that's the people that we want to use. And from there, we can figure out how to keep the patient out of the hospital and use specialists that work for the patient and the primary care physician to try to improve the the disease mix for every individual patient. But I think we can make a huge impact on the misery that primary care physicians are feeling. We can cut the employers from having to spend $1,000 per member per month to probably, well, we'll talk about what to do with how much money we can save. If we can provide that same level of care for less than $500 a month, I think we should charge $750 a month and reserve $250 a month in a health savings account for every patient. And that fund could end up accumulating into millions of dollars before retirement if the patient doesn't have any catastrophic illnesses. And we need to dramatically increase the use of laboratory, but we need laboratory tests that really help us prevent cancer. Like there's a thing called a liquid biopsy, a blood test that'll show a patient's going to get cancer as much as 5 years before there's a palpable mass or a mass that would show up on CAT scan or MRI. So we need to start using laboratory tests that can help us avert expensive illnesses and prevent misery and suffering and death by finding disease much earlier. And the same thing with immunology. When you have these people with COVID and long COVID and autoimmune diseases, we need to have laboratory tests that tell us how the immune system is functioning or not functioning, and then hopefully we can come up with drugs that can moderate and modulate those things. And we can do a whole lot better with pharmacology. There are just around the world, there are so many drugs that we don't use in America just for not for very good reasons. We just have a lot of opportunities to do better, and uh, I just can't wait till we have XHealth and we can begin to accumulate the data necessary to find out what is the ideal way to treat patients, both patients that have disease and for screening to keep people healthy. So keep that in the back of your mind. XHealth is the future of healthcare. And thank you very much.